However, reason why I'm telling you about this is because when you come into the hospital, homeostenosis speeds up. So this is where we're going to talk about hazards of hospitalization. So you don't, when somebody's hospitalized, you don't have that extra time to account for the gradual bone loss. You don't have that extra time to account for the decreased pulmonary reserve or the decrease in kidney function. It happens very quickly. And being in the hospital, there are some things that we do to patients that actually makes the aging process go faster. So immobilization. Patients are sick. They sometimes can't get up. They sometimes can't breathe to get up and move around. But a lot of times, either because we're apathetic or because it's just part of the culture, well, that's not my job. No, it's not my job. No, it's not my job. Then patients aren't gotten up and out of bed. When they're immobile, for every muscle group that you do not contract daily, you can lose 5% of your muscle mass. So if you have a patient who's in bed for a week and doesn't contract their muscles like this in their arms, they will lose 1/3 of their muscle mass in a week. That's incredible. That's a lot. And I don't know what your average length of stay is in the psychiatry unit, but I can tell you that, you know, if an average length of stay is even 4 days, if that patient isn't gotten up, they're going to be back in the hospital 2 days later.
Yeah. We don't take patients that don't get up. I mean, they have to be.
You don't? Okay. Okay. But things happen. People are misrepresented. I'm familiar with that concept. And before you know it, you get, this isn't what they told me I was, you know, this patient was like. So, not to point any fingers, but another thing that we do to patients that hastens the homeostenotic process is medical testing. We do not have to do a lot of the tests that we do on patients. I often advise my residents, don't order tests you're not going to do anything about, okay? Even if there's a test that may help with prognosis, talk it out with the family. Do you really need to know what this test is going to tell you? There's nothing we do that doesn't have risks. Blood draws have risks. Blood draws, in your scenario, if you had frequent blood draws, you might have patients who are really anxious or even psychotic, think that you're coming to get them. They may have breaks. They may become very delirious as a result. You know, in my population, which is, yes, we do have problems with delirium, but more on the, less on the psychiatric side, you know, we do CTs that aren't necessary, MRIs. Oh, we forgot to do that CT with contrast. Go back and do another CT. Patients get scared. They get medicines they don't need. They don't get medicines they do need. And it's a problem, which leads me to the next one, inappropriate medication regimens. When you have a patient who comes in, and a lot of our elderly patients are cognitively impaired, unfortunately, and a lot of them don't have people who speak for them. They come in, they don't know what medicines they're on, they don't know how many medicines they're on, so you don't put them on the medicines they were on before, they can have withdrawal. Or you come in and you didn't realize, oh, they're already taking that medicine, and you put them on a similar medicine and they kind of get double dosed. Or you forget they need medicine for depression or anxiety or for pain. So it's not just too many medicines, it's just inappropriate medicines. And then something that we do very poorly in the hospital, I think this is a nationwide epidemic, is poor communication. So with your older patients, there are a lot of similarities between the geriatric population and the pediatric population. You wouldn't just send your 3-year-old to the doctor and not go with them. The child can't speak for themselves. You are part of the decision making. You are the caretaker. It's the same with elderly patients. They don't come alone. If they do, it's often an issue. But they come, they bring their caretakers, they bring their families, they bring their cousins, nieces, whoever speaks for them. And those people need to be involved in the process. And a lot of times we don't involve them. And a lot of times they have information that the patient doesn't have. So by virtue of these, some of which are our doing, some of which are sort of a system-wide problem, these are some of the reasons why the aging process increases when patients are in the hospital. So what are some hazards of hospitalization? What are some things that happen? Patients get delirious. About, I think it's 1/3 of patients who present to the ER either are already delirious or become delirious while they're still in the ER. and I think it's half of hospitalized patients, same thing. They're either delirious when they get there or they get delirious very shortly after.
These are the older adults?
Yes, I'm sorry, in the elderly population. We talked about decreased muscle mass. You don't contract, you lose the muscle mass. Decreased pulmonary reserve, we talked about that too. Loss of plasma volume. So I'll give you an example. And Valium is a very lipophilic drug. In other words, you need fat cells to process Valium. Okay, so as you get older, even if you work out and do your best to keep up your muscle reserve, you get more fat to muscle volume. All right, so somebody who's older who takes Valium, it will stay in their body a lot longer than somebody who's younger, even if they have the same BMI. It's just because their body composition is changing. Bone loss, we talked about. Urinary incontinence is not part of the homeostasis process, right? Urinary incontinence is not a given. We think sometimes that will eventually happen, but it's not a given in all older patients. But as a result of being immobilized, being restrained, there is an increase in urinary incontinence. Sensory incontinence. Incontinence I define as the inability to have control. So if you don't have control of your senses, as you get older, your vision changes, your hearing changes, and hearing proboscis or natural hearing loss is sort of a given, vision plus minus, but most likely you'll have visual changes. But when you're in the hospital and the family says, oh, I don't want mom to lose her glasses, I don't want her to lose her hearing aids, I'll take them. And then mom wakes up, can't see, can't hear, doesn't know where she is, I mean, can you imagine how scary that would be? That's awful. I actually wanted to do this experiment with the residents about like restraints and taking away their glasses and that kind of stuff, but it didn't work out so well. So I'll just have you imagine that. Pressure ulcers and skin breakdown. Because you ideally take people who are ambulatory, you probably don't see as much, but you can imagine, you're in bed for long enough.
We've had some pressure ulcers.
Yeah, and sometimes, it's, you do your best and the skin breakdown still happens. So these are some of the probably more dangerous things that can happen. This list could probably go on we could probably be here for another hour discussing this, but I'll just leave it at what I see most commonly. I thought today, dehydration. People come in, oh, we'll leave them NPO, they might have such and such test done tomorrow. The test doesn't happen, the patient's NPO, they're too confused to be able to even ask for food, and before you know it, they're completely dehydrated.